The workup for an advanced disease patient has actually grown a lot more complicated over the last 10 to 15 years. At the turn of the new millennia, our pathologists had one job: to distinguish non-small cell from small cell. By 2005, 2007, the histologic distinctions between adeno and squamous, or squamous and non-squamous, became much more important with the emergence of angiogenesis inhibitors, whose benefits were really confined to the non-squamous population. And a little bit more recently, the recognition that pemetrexed seems to have preferential benefits in adenocarcinoma with really no identifiable PFS or survival benefit in squamous or non-adenocarcinoma. More recently, certainly within the last decade, we have recognized the importance of molecularly based therapy. Most of this is mutation-based. Some of it's based on the identification of genetic translocations, which strictly speaking are not mutations. So I group them all under the label of genetic-based or molecularly based treatment. And that story is continuing to transmute rapidly. First, we had EGFR mutations, the observation of response rates in the 60, 70, 80% range, treatment-naive patients who were exposed to the EGFR TKIs, progression-free survivals that were far better than we'd observed with standard chemotherapy, and which were verified in multiple prospective phase 3 trials. We've seen now the evolution of acquired resistance and the observation of T790 as a predominant mechanism of resistance in those with actionable EGFR mutations. By the same token, around 2009, 2010, we recognized the importance of ALK translocation. So not a mutation, but a rearrangement of genetic material on the ALK gene, and usually with some other partner protein such as EML4. And it was much less common, maybe 3 to 6% as opposed to the 10 to 15% that we've observed with EGFR mutation. But again, a whole fleet of therapeutic agents that have emerged that have preferential benefit in this population, benefit that far exceeds chemotherapy in the same population. And here too, irrespective of the nature of the mechanism acquired resistance, we've seen the emergence of second and even third generation agents that will salvage these patients who initially responded to crizotinib, the first-line agent, then have developed disease progression and yet respond again to a second-line oral agent. This is unprecedented. I've been practicing thoracic medical oncology for nearly 30 years, and I'd have to say it's really in the last 8 to 10 years that we've seen the majority of progress in this disease, at least in my professional lifetime.